Welcome everyone to this research room. The MAPS Canada Research Room is a monthly webinar series dedicated to showcasing cutting-edge Canadian research across diverse disciplines within the burgeoning field of psychedelic studies. Our mission is to democratize access to psychedelic science and fostering inclusivity through knowledge translation and dissemination of academic knowledge in a more accessible manner. Each research room session is an hour long and provides researchers a platform through which they can dynamically engage with the audience about their current research. If anyone here is interested in presenting or would like to see someone present, please do drop us an email at researchroom@mapscanada.org. I'm going to put the email in the chat, so feel free to suggest any future presenters. The research room is organized by myself, Alkione, and Lila. And tonight I would like to welcome Dr. Ronald Shore, who is a research scientist with Queen's Health Sciences, an assistant professor in the Department of Psychiatry at Queen's University, and a scientific advisor to the Canadian Institute for Military and Veteran Health Research. Ron is an investigator and lead therapist at Queen's in a trial of psilocybin plus motivational enhancement therapy for alcohol use disorder. His PhD is specific to the clinical application of psilocybin, and Dr. Shore is also faculty in the Michener Institute Foundations of Psychedelic-assisted Therapy educational program and is the founder of Kingston Street Health Center. Apologies if I mispronounce the name of that. English is not my first language. So thank you very much, Ron, for being here today. And we look forward, I'm going to stop sharing my screen, and we look forward to hearing from you.
Thank you very much. I'll just get all set up here. Can you see that okay?
Mm-hmm. That's perfect.
Okay. There we go. Okay. Well, thank you very much and welcome everybody. This is a kind of sweet little group. It's a nice way to spend a Thursday night. As many of you know, we're also meeting just a day after a significant development on the regulatory side. So I'm going to talk a little bit about the advisory committee recommendation or decision on the MAPS Lycos MDMA application for PTSD that was heard earlier this week. So I'm going to talk a bit about that and put things in context. But before we go on, just I want to just thank you all for being here, spending some time together, and thank to MAPS Canada for hosting this. This is an important series, and I was mentioning I actually was part of this earlier, maybe 5-6 years ago. I was part of doing a presentation. Where is the, I can't see how I'm advancing the screen here on my computer. Oh, there we go. Okay. So you saw my bio, I won't repeat it. Just as an academic, I just want to make sure I'm clear about my conflicts of interest. So I'm employed by Queen's in a couple different fronts. My background and the lens I bring to this is really community health, drug policy lens. I was part of the early generation of harm reduction kind of activists in Canada. It started needle exchange and harm reduction and overdose prevention programming in the early 1990s. And I spent about 35 years in community health and mental health and addiction. I've taught drug studies and addiction studies at Queen's. I've taught in the Psychedelics program at University of Ottawa. Just defended and graduated my PhD last year at the age of 54. So later in life, kind of full-time academic. And my PhD is a review of the therapeutic application of psilocybin. So I did a deep dive there and came up with a novel, I think, contribution to understanding mechanisms. But in terms of conflict, I spent a couple of years consulting with a group called Dimensions here in Ontario. They have a retreat center in the kind of Muskoka area in Ontario, just north of Toronto. And I spent some time with the Dimensions group, kind of developing evidence-based protocols for how to do psychedelic retreats. And as part of that, I was a grad student at the time. I received some shares, and I continue to be a shareholder in Dimensions. So obviously that's a slight conflict of interest because I actually study this in the field as well, but it's all good as well as long as we develop it. So if we're okay to jump in, this is what I've been asked to present on. And this was a real neat opportunity for me. I guess 2 years, when was it? 2023. That's correct. So we were putting it together the year before. It came out in November of last year. And so the Canadian Institute of Military and Veteran Health Research, which is located here at Kingston, and is really a national collaboration of academics and stakeholders interested in veteran health and military health in Canada, invited me to guest edit along with a colleague here at Queen's named Deji Orendide, who is in psychiatry here as well at Queen's. And we together co-edited or guest edited a special edition of their Journal of Military, Veteran, and Family Health research. So it's kind of early in this area. As you can see, if you get a chance to check out the full journal issue, there's a number of publications. A lot of them are reviews, a lot of them are commentaries. There's some stakeholder submissions from veterans as well. Monica Williams has an excellent preface, if you know Monica and her great work at the University of Ottawa. And Erica Dick, who is on the call tonight with us, Canada's preeminent psychedelic historian and one of the most important scholars we have here, who is actually with us tonight, has an article there as well worth reading. And this is my editorial I've been asked to present. So it's not so much original research as much as a kind of review on special considerations. If we're looking at applying psychedelics or expanding the kind of research or clinical application into more veteran communities, what I wanted to look at is, are there unique or special considerations? So you can kind of see the journal issue itself had a beautiful cover page. The artist did a really nice job. And that's the kind of shot of the article. But the interesting thing is, just before this issue came out, around the same time, the Special Senate Subcommittee of Veterans Affairs, this is the Senate, part of the Government of Canada here, presented a report called The Time Is Now, which called for an immediate and robust program of psychedelic research for veterans in Canada. So this brought a whole lot of media attention, got a little bit of traction. As you can imagine, the Senate is kind of an advisory body, and they have some sway, but it's not, they don't have any legislative authority. So no money flowed with this. So it's been a bit of an exercise in, I guess, both opportunity and frustration then, to try to keep veteran health at the center point of kind of public awareness. And I'm going to talk a bit about why it's so important, but this is just a shot of a couple of senators when they released the report. You can find this online. It's called The Time Is Now. It's quite good. But firstly, let's talk about, I guess, what's just happened this week. So for those of you who don't know, the FDA in the States is in the final phase of the reviewing the Lykos MAPS application for regulatory drug approval for MDMA to treat PTSD. So as we all know, MAPS has been at this for a long period of time. We've had successfully completed several phase 3 trials, including Canadian sites. And if you look at my publication, the original source, you'll see an appendix with all of the clinical trials listed. So if you go onto clinicaltrials.gov, you'll see just how many MDMA trials are in process now, many of whom MAPS are Lykos sponsored, but also Veterans Affairs in the States is directly sponsoring trials of MDMA, not just for PTSD, but conjoint therapy with spouses and partners, looking at the kind of family healing within veteran communities. So it's well advanced in the research. We know that the findings have been noteworthy and quite positive, particularly when you're looking at a condition that's been hard to treat. So there's a lot of excitement around this. So there was a bit of a surprise and a bit of a shock for some people that the advisory committee, which is a group of specialists brought together by the FDA to comment and kind of make a judgment on this submission, actually voted against it, and a strong majority. So if you want to find out, I won't go too much into all the details. I'll touch on some of the issues, but the nice thing about the FDA, it's all online. You can find all of the decisions, all of the submissions, all of the briefs that were submitted online. And we're going to talk a bit about kind of what the issues were that were identified. My own take on this is not the end of the world. This is tough stuff. Psychedelics are at the forefront of the psychedelic regulatory drug approval process. It has a high bar to pass. We're building capacity and knowledge as we go through it. And there's no doubt that people talk about this as a paradigm shift. So if we want to take that literally, it takes time. It takes time to make these changes. It takes time to prepare clinicians. It takes time to train the therapists. It takes time to educate the regulators, all the regulating bodies, the colleges that oversee physicians, psychotherapists. They're all trying to figure this out. So it's going to take some time. So I wasn't really surprised, but it does seem like a setback. I would say that, it's not going to be a permanent setback, and it's an opportunity for us to kind of move forward in some ways, but I'll talk a bit about that. What they identified were some challenges in psychedelic research, and these are general. These aren't specific to the Lykos submission, but these are some of the issues that were mentioned in the Special Advisory Committee kind of ruling on this. And one is this well-recognized difficulty in blinding. So when we're doing randomized controlled trials, the gold standard is randomized double-blind, placebo-controlled. Nobody knows who's getting what. I have the good fortune here of not just being an investigator in psychedelic trials, but I'm also a therapist in a psilocybin trial for alcohol use disorder. And it's been a remarkable experience. So I can speak firsthand to some of the challenges in trials where there are inactive placebos, so there's no physiological response, and the enormous expectancy of the patient population and the investigators really does seep into the trial design and makes it difficult to, what I would say, carry out what would be the clean or pure science. But I'm not sure that exists. I'm not sure that model exists. And I don't think we always apply that. But we're applying a high standard to psychedelics. The lack of ability to blind is real. You can tell when someone's on a psychedelic. There's physiological signs, there's behavioral signs. And so that creates expectancy for everybody. And that's just part of the flaw in these things, but it's maybe unavoidable. The other is what I would call contagion effect. And Suresh Muthukswamy from New Zealand has some excellent papers on this, and Tenzing Norani as well, in terms of Dark Loops paper. If you're interested more on psychedelic trial design and contagion effect, read those papers. It's really about the level of interest we're bringing in this field. A lot of us are scientists, researchers, and advocates. MAPS Lycos is not only kind of regular. It's not only a making this submission, but there's an advocacy behind MAPS to kind of make these changes in terms of policy. That's a bit unusual in medicine. So that creates some of this contagion, which is now we have a lot of hype around psychedelics. The Michael Pollan book was a big part of that. The level of interest in psychedelics is off the chart. The number of people microdosing is quite high. So it's something that has taken on a hold of the popular consciousness. So now when, for example, patients come into a trial, they have a lot of expectation that psychedelics are going to heal them. It's going to fix their addiction. So we're having to kind of get a little more nuanced understanding of just how this works. It takes time, but that contagion effect means people come in with the power of belief and expectation. And that affects both the researchers and the patient experience. Other things here is just, I think we've maybe not done a great job of reporting adverse experiences in psychedelic trials, in part because of the regulatory classification issues and the interest in getting it legalized. I think there's a bit of a non-neutrality sometimes we have, and I think we need to be careful there, but I think safety is paramount. These are interventions which are powerful and effective, efficacious, I would say, but at the same time, they carry risks, and they can result in long-term changes to people, including the domain of personality, which is quite unusual in psychotherapy that you see shifts in personality per se. So we know suggestibility is high in psychedelics, so we have to be careful. We know there has been abuse, including at Canadian sites in MAPS run trials. So we need to do a better job of kind of overseeing, make sure patient safety is paramount. So all of this is good, that these are the things that are highlighting that we can improve. I'd say that leaves room for progress for it. But I would say the other thing that I continue to struggle a little bit with, like I understand, like in our psilocybin for alcohol use disorder trial, it's a manualized approach to therapy. I know MAPS has a manual for the therapy, but the exact therapeutic model and how it's working and what's being discussed and the underlying mechanisms, I think we need a little more clarity on what those are, maybe a little more standardization and being more explicit, so that not only do you have adherence by different therapists across sites, but people in the public have a large understanding what the therapy is and how it works when we're looking at the combination with MDMA. So I think we can do a better job expressing that to the general public. And we still, in terms of underlying mechanism, we're still really trying to figure that out. I think with MDMA in particular, we're looking at kind of memory recall and taking away this emotional charge of trauma. And so there's a neuroplasticity and an emotional recollection of memory, but clearly that's implicit in the mechanism. But there's also a very strong attachment. There's a very strong therapeutic rapport, which is a huge part of healing for people with trauma. So we're still trying to figure out a little bit the mechanisms, and I'm sure people will have their own perspectives on that. But I just wanted to give an overview on some of the challenges in these trials. On a more personal note, this is my dad. I am the son of a veteran. I come from a very military family. My dad joined the military actually in Canada at the age of 16. Technically, that's a child soldier in today's world, but there was a program called the Soldier's Apprenticeship Program in Canada in the 50s and 60s, and it took kids from troubled homes and largely gave them a career in the military. And my dad had an amazing career, and he managed to have a wonderful family. He passed away about a year ago. But this is him leaving the Congo. He was a peacekeeper with the United Nations in 1962. and was in the Congo during a time of incredible genocide. Witnessed things that he never recovered from. It was a long-term project to even get my dad to talk about it. And he really, this is an event that shifted our family's life. Not only did it shift his life, but it shifted ours. He came back with undiagnosed PTSD, with clear moral injury, unable to process what he had seen. And he developed a series of PTSD-related kind of behaviors that affected our family, my brother, my sister, and my upbringing. So my grandfathers were also in the military in World War II. My uncle was a tank driver here in the Canadian military. My brother is a veteran as well. So I'm steeped in the military and veteran kind of world. And I have a soft spot, obviously, to try to improve the care, particularly for veterans with PTSD. There's my dad, John William, or Jack Shore. So I'm just going to move something here so I can see better. Just by way of background, and I know we don't have a ton of time tonight. So because this is almost like a journal club approach, I've just taken excerpts from the article just to highlight a few things. I won't read them all, but you can go and look at the article. But just to set the context, Canadian veterans have significant health risks and burden of illness that is attributable to their vocation, their profession. We've now had a couple generations of Canadian soldiers who've seen active combat. My dad served as a peacekeeper, and my brother served as a peacekeeper as well. But we were fortunate in the time of their military service that was before Afghanistan. So we've now had Bosnia, Herzegovina, Afghanistan, Rwanda, and massive trauma, massive loss, combat-acquired trauma. And Canadian military are unique, I would say. And I would say part of the reason we need to develop more research on Canadian veterans is to disaggregate it a little bit from the American military kind of culture. And there's no judgment. I'm just saying there's cultural differences between the nations, and I think between the militaries. But combat acquired PTSD is going to be common across. But there's something about Canadian veterans that I think there's a unique sense of public service, of high calling, of responding to moral duty. And I'm not saying that doesn't exist around the world, but maybe I'm just kind of knowing a lot more of the Canadian soldiers. I understand the good intention behind service for a lot of people. And so they come back quite wounded, quite not just physically wounded, with more likely traumatic brain injury, sustained concussions, other injuries, but the psychological injuries too, not only of losing comrades, but of seeing what people have seen and being involved in things that are difficult, that only soldiers can probably understand, and then coming back and trying to reintegrate into society. And I will ask at the end of this talk, my friend and colleague, David Fascinato from Heroic Hearts Canada, which is a veteran-led advocacy group. I'll ask you to speak a bit to that, David, if you don't mind. After all, you do a better job than I am now. But this is just to say there's a whole combination, and there's considerable interest in looking at PTSD, not just as a singular construct, but as this kind of hybrid that often includes substance use and depression. Like if you look at how often they coexist in someone, or concurrent, so you'd have addiction, depression, and PTSD, there is a question whether or not that's a single construct. Are those separate disabilities or disorders? Are they all one? So, but we do know high rates of suicidality among Canadian veterans, which is in part why psychedelics with veterans is a much more nuanced, I would say, intervention. I'm not saying that all patients don't deserve a high level of safety consideration, but the high rates of suicidality and the very particular way in which the PTSD is acquired for Canadian veterans creates some unique risks in psychedelics. And I'm going to talk about that a bit as well as we go on. So just, again, we know that depression, substance use, quite common. These are coping strategies people involved to help self-regulate, particularly after trauma. So it's not a surprise. The state of the evidence now, I think generally, and this was written before the FDA subcommittee or special advisory committee ruling this week, but my sense is, as a research scientist, there's credible, compelling, and mounting evidence to support the use of MDMA in the treatment of PTSD and psilocybin-assisted therapies for treatment-resistant depression, major depressive disorder, substance use disorder, and anxiety and distress due to advanced disease. So those are the ones. MDMA for PTSD is at the head of this pipeline for regulatory drug approval. Behind that will be psilocybin, primarily, I think, for depression and for substance use dependence after that. There's a case to be made, both humanitarian and clinically, for more interest in looking at this at end of life, in particular for advanced cancer, to deal with demoralization. I'm talking about psilocybin now. Very positive outcomes in the trials. And I've had the experience of kind of being part of that with some people with a special access application. And it's a remarkable experience for someone to help prepare or deal with advanced disease and mortality, meaning, legacy, spirituality. These things really do, these are interventions that really may help people at key times in their life and illness. Ketamine is a whole different kettle of fish. And I don't want to talk too much about it. I will say, and I know there may be people here with kind of different views, but the systematic reviews on ketamine show rapid antidepressant effect. And it does appear like there's an effect to help with addiction. It does seem to help with substance use disorder, but the benefits appear to be short-lived compared to those we're seeing with MDMA or psilocybin, where there is more evidence of persisting effect. So most of the ketamine clinics that I know now are doing infusions every 2 weeks, because that's about the time period people will get. So then my only concern is there's a biological impact of repeated ketamine infusions, particularly on the bladder. So how are we dealing with those biological complications if this is what we're kind of coming to? So this is all to say we need to continue to develop new trials. There have been no trials yet on Canadian veterans. In the American trials, there are veterans included, and there are some veteran-specific trials now in the States, funded by Veterans Affairs in the States. So what is PTSD? I'm just looking at the DSM-5 here criteria. So we're looking at the presence of recurrent, intrusive, and distressing memories or dreams, dissociative reactions such as flashbacks, reactions to internal or external cues that resemble aspects of traumatic events experienced, characterized by enhanced activation of the nervous system, of the sympathetic nervous system in particular, serious mental health condition, public health problem, high burden of illness, as well as growing economic implications. So it's a great predictor of disability in the community and in veteran communities in particular. Available treatments today have limited efficacy, although there are a range of available treatments, including psychotherapy, antidepressant medications, exposure therapy, I'll talk about in a bit. But we know that PTSD has a high rate of relapse, and 40 to 60% of patients generally do not respond adequately to hit like a clinical response to current pharmacotherapy. So there's a need for novel therapeutics. I'm not getting into like dissociative subtypes of PTSD or complex PTSD. I'm just going to kind of keep it at this level for now. But we know that, you know, often there's traumatic brain injury, chronic pain is quite common as well, and high rates of depression and substance use, as I've said. So we're concerned here with rates of suicidality, rates of addiction as well. So what do we know about MDMA? You know, my background in this, because I came out of a kind of drug awareness area and taught drug studies. I'm really interested in pharmacology. A lot of my thesis is on pharmacodynamics and neuroscience, the neurobiology of psilocybin in particular. And my take on drugs has always been, and it comes from the harm reduction perspective, like know what you're putting in your body, know how this works, make an informed decision. So I think what we need to remember with psychedelics all the time is start with what's the pharmacology, how does this work, what's happening in the body, talk about set and setting, but let's not kind of bypass pharmacology. And so I find sometimes in psychedelic circles we do, as if it's somehow an inert influence, and it's not. There's very clearly medicinal or therapeutic impact of the substance itself. With MDMA, and I'm primarily a psilocybin scientist, but I'm broadening into more MDMA research because of my interest in veteran health, and that will be the lead psychedelic treatment for that anyways. So I'm interested in the kind of underlying mechanism, how it works. And what you have in MDMA that you don't necessarily have with psilocybin is this oxytocin-driven attachment kind of experience that happens with MDMA. And I don't know if people have used recreational MDMA or have had experience of this before, but this idea that it just sits on your fear and it goes, you know, you just feel such profound love and connectivity to the world. That is huge therapeutically, which is why the Shoguns originally thought of this as an intervention for couples to improve relationships. Relationality is a huge part of MDMA therapy, less so in psilocybin, where it's more of an internal journey getting to relationality. But there's something about MDMA where there's this outward orientation of connection with people during the therapy. And it's more of a psycholytic form of therapy where there's more talking involved in the medication session, obviously before and after as well. But with psilocybin, there's not as much talking. There can be some, but we generally direct people back in. There's a little more talking happening with MDMA in these therapy sessions, which is fair enough. And there's reasons for that. But we know that these kinds of experiences are thought to not only strengthen therapeutic rapport and alliance, but to improve emotional regulation. And most importantly, and this is talking about mechanisms, promote the review and extinction of learned fear associations. So this is super important, and this is where we're getting into the role of the amygdala and of past fear conditioning. And this is where MDMA and psilocybin are both similar in the sense that they attenuate or reduce the effect of past fear conditioning. It lessens the impact of trauma, and it allows for, when the memory is recalled, it's recalled into a context of more positive social environment with attachment, oxytocin, this feeling of connectivity. So the emotional negative charge is kind of taken away because it's the new contextual memory is then filed back, and you get a lessening, theoretically, of the symptomatic PTSD effects, particularly on the autonomic nervous system and cortisol regulation. So neuroimaging really has shown us the association between improved negative memory processing and reduced amygdala and hippocampus activity. So you want to reduce the amygdala activity, better connectivity to the hippocampus, gets us more into the limbic area, emotional processing, sensory awareness. You're more present when your limbic system is more activated. And so this elevated level of self-awareness is thought to have cognitive benefits related to MDMA and is therefore useful as an adjunctive therapy in combination with psychotherapy for a number of possible psychiatric disorders. So the psychoactive effects of MDMA elevate mood, increase sociability, increase interpersonal communication, and facilitate imagination. So as a therapist, that's a gold mine. That is just gives people flexibility, gives them tools, gives them a boost, a help in kind of processing. People need help, you know what I mean? We get stuck. We're stuck often in kind of ruminative or negative feedback loops. We need to shift out of those. Experiences like this can help that shift. Real changes in the memory, neuroplasticity, raised levels of monoamine neurotransmitters in the brain, which are very important. So it increases pro-social behavior, affective contact, pleasure, and emotional empathy. This is all obviously important to the human condition. And it may be of benefit to intimate partners as well. And you'll see there's some trials already in place looking at that. So what are the risks when it comes to MDMA? And again, I come out of the harm reduction community, so we would have done a lot of kind of drug awareness campaigns around raves and ecstasy and kind of street level or naturalistic use. So what we know, it's the same clinically or naturalistically. The pharmacological effect is going to have the same kind of possibilities of increased anxiety, diminished appetite, headache, jaw tightness, which is that telltale MDMA grind. Each are transient and typically they self-resolve. There's a transient or short-lived increase in systolic and diastolic blood pressure, as with psilocybin. And I will say, as with heart rate, so when you get that increase in blood pressure and that increase in heart rate, and there's a concurrent increase in interoception, or your awareness of your own bodily processes in both MDMA and psilocybin, that can create an anxiety type response for people where suddenly they're feeling their heart, they're sensing their breath much more than they normally do. Plus it's elevated because of the slight stimulant effect. So it can create an anxiety type feeling unless people understand it's transient, part of the drug effect. But it also then is a tool to become more aware of your breath, become more aware of your heart. And that's something I use in psilocybin therapy. But as with psilocybin, some forms of hypertension and severe heart pathologies are contraindicated, particularly valvular pathologies. Most common adverse experiences in the trials include headache, muscle tightness, insomnia, anxiety, and nausea, fatigue, all transient, with most participants reporting their severity as mild to moderate. Research suggests, and this is in psychedelics in general, and let me keep an eye on the time here, make sure we have lots of time for questions, that in addition to pharmacology, the extra or non-pharmacological variables are super important in psychedelic therapy, so set and setting. So we know that psychedelics have a demonstrated sensitivity to setting, suggestibility, and language. Given the potential for challenging experiences with psychedelics, it's considered unethical to provide psychedelics in clinical trials without at least a minimum level of psychological support. But there's variation in how much psychotherapy is provided depending on the different models or what school of psychotherapy is provided. This is psychedelics in general, not the MAPS trials. Treatment programs that reduce or minimize the positive contextual factors such as preparation, therapeutic alliance, and time spent in integration may increase the likelihood of adverse experiences. Furthermore, several states or traits common to living with PTSD are variables that have been identified as being associated with negative and challenging experiences while under psychedelics. And these include the following: preoccupation and apprehension, attachment avoidance, inability to reappraise emotional response, and general psychological distress. Levels of rigidity and preoccupation and the absence of openness before psychedelics can diminish the effect of the psychedelic compound. And trial participants who scored high on traits of absorption, openness, acceptance, and surrender are generally more likely to have positive experiences. veterans with acute PTSD, with or without the dissociative subtype, may be at greater risk for negative and challenging experiences. That's kind of my whole point here. We don't know. We need to do the research. We need to do it carefully, and we need to include more veteran voices at the table to understand this a little better. But we do know that with MDMA compared to psilocybin, you don't necessarily get the full ego dissolution experience. And you also have this acute positive pro-social oxytocin-driven kind of attachment experience in MDMA, which is helpful for people going through difficulty. So although low-dose psilocybin is associated to reducing fear conditioning, I'd say MDMA is still should be considered among the psychedelics, the lead psychedelic treatment anyways for PTSD. Whereas if addiction or depression, end of life, I'd veer more towards the psilocybin side. Moral injury, I'm just going to touch on quickly. I want to leave lots of time for conversation. There is a trial now looking at MDMA for moral injury. Moral injury is an important part of the veteran experience. It's not just the PTSD. It's this more non-diagnostic cluster of symptoms that we can kind of form a syndrome of biopsychosocial and spiritual suffering resulting from participating, witnessing, or learning about events that transgress one's deeply held moral beliefs. It's associated with impairment in relations, health, occupational function. It's a significant factor in operational stress injuries among Canadian veterans, contributes to worsened mental health, causes social difficulties, and can contribute to a sense of a fractured identity. So as I said, there's one current trial. So I'm going to start to get into my conclusions here, the future of the research. We need to improve military and veteran-oriented psychedelic research. We need further trials, including trials that are larger, longitudinal, multi-site, and include a variety of patient groups as well as active placebos. So this is in terms of psychedelic research in general. Trials to date have been limited by expectancy bias and the difficulty in blinding. The clinical trial literature can also be augmented by improved investment in observational and naturalistic studies. Better reporting of the therapies provided during trials is necessary, and we need more improved, detailed, and transparent reporting of adverse experiences. I do want to put in a plug. Most of our approach in psychedelics is individual therapy. I think there's a real role for collective healing, like you would see in an ayahuasca ceremony. This is actually a picture of a Santo Daime congregation. But I think veterans in particular respond well to the social approbation of peers, to the sense of community, of colleagues, of comrades, and healing is often social. And so I think even from a cost-effective perspective, we need to look at being able to do these in more group settings, maybe with just the integration in groups to start, or perhaps collective ritual as well. My closing argument here is Veterans Affairs Canada is a fantastic, unique opportunity because it's an ecosystem responsible for veteran health. As a health planner, health researcher, health scientist, when you can identify the patient population clearly, it's really helpful to meeting their needs. So very clearly, we have an identified veteran community, and Veterans Affairs Canada is responsible for their care. We have a moral bound duty as citizens and through the government to take care of our veterans because of their public service. So the VAC could be considered optimally an ideal ecosystem because there's an overall responsibility for health in terms of insurance, provision of programming, that kind of thing. So it's a good opportunity, but we need to look at a coordinated, comprehensive program. We need some trials, particularly on Canadian veterans. I would say there's a little bit of a resistance to doing psychedelic trials in veterans in Canada, in large part due to some past history where veterans maybe would have been unethically exposed to novel therapeutics or enrolled in trials that were unethical in the past. And I would argue that that is a thing of the past. We can do this much better. Veterans shouldn't be excluded from participating in research, but there's almost a protective high level of precaution around veterans in Canada without people wanting to seem that we're using people as guinea pigs who've already maybe suffered so much for the public interest. The other thing I'll identify is cannabis is a significant deterrent, I would say. I am not against cannabis legalization, obviously for cannabis legalization, but what is left in Canada now is questions over the rollout, how it was done. It really resulted in a real negative impact on the medical cannabis side. I think there's some long-term health outcomes to the way it's been kind of rolled out that are beginning to become clear. And with veterans in particular, there's high levels of cannabis dependence. So there's a reluctance among health planners and veterans health to do more trials on psychedelics because of some of the fallout from cannabis. I'll leave it at that. I don't want to get too judgmental into this. That's a whole other issue. So issues of safety are real. I'm concerned about ketamine. You know, like I'm not opposed to it, but I think we need to understand it more. I'll stop here. Here's the citation for the article. There's a reference here to a Newsweek article where I'm quoted in terms of talking about the FDA advisory committee. There's my email. I'll leave it there and we can have more conversations because I'd love to hear from other people. And David Fascinato, if that's okay, do you mind if I can just ask you to chime in a little quickly on the veteran experience around this and a bit about the role of Heroic Hearts Canada?
Absolutely. Thank you very much, Ron. And what a great presentation as well. And thank you to MAPS Canada for putting together this great platform to share your insights. And I don't want to repeat your talking points or anything like that because I'm very much in agreement and alignment with a lot of your perspectives and our past conversations have sort of shaped that. But I guess to cut to the chase, we are a charity that strives to foster access to and research on the safety and efficacy of psychedelic-assisted therapy for veterans at home and abroad. And to your point, I agree, we do need to discuss the need for further research and to run through the constraints and limitations of current research around safety and efficacy. But, to your point earlier, I just want to underscore that there are really, there are true human consequences to the stagnation and the hesitancy, shall we say, around the current approach to unlocking research and access to psychedelic-assisted therapies. So, just to put it out there bluntly, like folks are struggling and are desperate for care. Too many of our friends, I'm a veteran myself. I know there's another veteran here on the call. Too many of our friends are struggling. Too many of our friends have taken their own lives. Too many of our friends and folks that have reached out to Heroic Hearts Canada, and it's so frustrating. We're not in a position to help yet, but they're desperate to heal. They've explored often all too many avenues, whether it's traditional talk therapy or traditional pharmaceutical approaches or a combination thereof. And I guess this kind of highlights for me and my experience in working within the veteran community and now within the psychedelic space, the fact that the current standard of care for veterans is insufficient and frankly is failing all too many veterans. Too many folks are at the end of their rope. So we collectively, as an organization, owe it to our friends and former colleagues and those seeking out or who are interested in learning more about these treatments to provide them with the opportunity to access these therapies and treatments, as well as advancing the necessary research around the safety and efficacy so that we can contribute to a broad-based, equitable outcome where all Canadians could potentially stand to benefit. So, at the end of the day, there's no better way to advance and talk about research than to also advance and talk about access hand in hand to generate the vital real world data in addition to the clinical trials you outlined that can help push the needle forward in a critical way for those who are suffering right now. So, happy to sort of, I don't want to jackknife this and just talk about Heroic Hearts for the next 45 minutes. Just kidding. But if you would like to reach out or learn more about Heroic Hearts Canada, you can visit our website, heroicheartsproject.ca, or reach out to myself. We have a lot of things in the hopper, very exciting, that sort of supports many of the points you discussed tonight here, Ron. We have observational and retrospective observational studies that are ethics approved and ready to go that are in the hopper and ready to deploy. And thank you very much for putting that link in there as well. And I'll also drop my email and contact information for any of those any folks who do want to reach out to me. And, I just want to underline as a final point, like we're as a veteran-led advocacy organization that seeks to promote access and research are all in on working with the scientific, clinical, research-based community, as well as our partners at MAPS Canada and across the psychedelic ecosystem to get this done and move this across the finish line. I like to say we're not even at the starting line yet. And decisions like this week sort of reinforce some of the critical mass that we need as a community to advance this further. But with that, I just want to say thank you so much, Ron, for letting me chat a little bit here. And thank you to MAPS Canada for such a wonderful series and a great platform to contribute to discussion on what we need to do. So back to you, Ron, and hope everyone enjoyed that as much as I did. Thank you.
Thank you very much, David. That's super helpful.
Thank you both. We can do you can do a Q&A now. So if there is any questions, you can either drop them in the chat, or feel free to unmute yourself and just ask your question if you'd like. Erica, you can go ahead.
Hi, Erica.
Hi, Ron. Thank you very much for that presentation. That was great. I have like a bunch of questions, but I'm going to try to limit them to two. One's really quick, and I'll just tag in another one as well. I'm curious your thoughts on why LSD hasn't come back into this. You talked about MDMA kind of being sort of at the front end, and maybe psilocybin. You mentioned ketamine sort of on the side, but I was just curious about that. And then the other question is my real question, and hopefully it sort of ties together David's comments with yours. You know, you mentioned, and we've talked about this before, like your history in harm reduction. And I couldn't help but hear those elements in your talk as well. Like some of this is borrowing from almost a extra or outside clinical context in order to inform some of the settings, but also some of the approaches. And then David's comments, and he didn't say this, David, sorry, I don't want to put words in your mouth, but it seems that there are cases where people without the FDA approval or without Health Canada's approval may take matters into their own hands and seek out these substances on their own. So I guess I'm just wondering if you can comment a little bit on your experience working in both of these different communities. Like, how can harm reduction and clinical trials work together in a more cooperative way? Or maybe it is more cooperative than I'm imagining.
That's a brilliant question. So I'll start with the second one first. So and we were talking a bit before the webinar. To me, it's like psychedelics. This recent advisory committee kind of recommendation or lack of recommendation really does illustrate the challenge of trying to fit psychedelics into the mainstream medical model. These are radically different experiences than most medical treatment. We talk about it as a paradigm shift. And so with the paradigm shift, it's going to be an odd fit in the master's tools, so to speak. To quote Audre Lorde, you need new tools to unbuild the master's house. So you need to kind of have different approaches, but we're stuck in trying to get it to people. And there's not a lot of appetite for decriminalization. You're seeing some backtracking on that, obviously in BC. And I think that's going to be a national backtracking with the possibility of a conservative government, which will be even more problematic for all of this, including harm reduction. So there's that going on. But at the same time, I'm going to throw in one more element here, Erica. What about the ceremonial traditions? Not just the underground naturalistic use, but what about the bona fide lineages of ceremonialism that left the jungle probably 40 years ago and had a worldwide diaspora, whether it's ayahuasqueros or mushroom therapists. Some people have been doing this in an underground way in legitimate manners for now decades. So where are we going with that? And part of what I'm doing now is writing a paper for one of the regulatory bodies. And you just really realize how complex this is to fit some of these altered states of consciousness, non-ordinary states of consciousness, into these mainstream tools. But the reality is we have a crisis in mental health. We need better care. So this is the best avenue to get there. I think MAPS has been clear. We need to medicalize to get the legalization. So we've kind of bought into that in psychedelic research. The harm reduction side, yeah, I think for some reason we tend to discount naturalistic or observational studies, prospective cohort studies, and we look at these gold standard trials, which are really, they're a construct. They do not in practice resemble what people think they are. And I don't think that's psychedelics alone. I think that's it's a widespread problem with randomized controlled trials. And most novel compounds take, 15 years to come through this process. And I think the success rate is less than 5%. So in terms of regulatory drug approval. So this is a radically different experience. How do you combine the harm reduction? It's an interesting thing for me. You want to kind of forward access, but at the same time realize that there's always going to be a cultural element. I think people have the autonomy and right to alter their own consciousness without getting into legalization and decriminalization. Where does that leave people in terms of a public health framework for how do we teach people how to use these substances properly if they're going to use them? I have psychotherapists who want to do psychotherapy with people who've done their own psychedelic thing, come in for therapy. I think that's problematic. So it's kind of this world that it's classic psychedelics, right? Like it doesn't really fit anywhere. It brings everybody together. It creates entropy and confusion. And it creates this criticality. We're all trying to figure it out, which I think this is one of the great values of psychedelics. I think in your writing, you've shown this, what it helps us understand about society, consciousness, beyond treatment, beyond medicalization. It's all these other fascinating conversations that come. In terms of your first question, why is LSD not made as much of a comeback? Was that what you were asking? You said not? I think my understanding, you're more of the LSD historian. I'm obviously, people kind of get it. I'm much more the psilocybin. It's for shorter acting, fewer adverse experiences. So I think psilocybin is more manageable than LSD. It's the same reason we're not doing ayahuasca in hospital settings. I think you can manage psilocybin in a hospital setting, and I didn't think that was possible a couple of years ago, but you really can do it in a hospital setting on an outpatient basis. I think that LSD just has a bit of a different risk profile. It's longer acting, but I'd be curious your take on that more than mine.
It's very similar to my take, just that
Okay.
some stigma attached to it, but I don't want to dominate.
Yeah.
I'll let Brendan get in there.
Yeah.
Brendan, would you like to ask a question as well?
Yeah, thank you very much. I really enjoyed your talk, and there's so many points to jump off on. First of all, I think Erica is exactly right. That's the relevant question to ask, and hopefully the Europeans have less stigma surrounding LSD and seem to be doing more research there. But I think it's certainly the best, far greatest potential of the whole bunch, and maybe the only psychedelic necessary for therapy. But I think we're kind of broken here in North America. I want to ask you a question because you're a therapist. First of all, it was nice to see you and David on the same talk. So it's a whole handful of handsomeness to set the tone. The one thing that struck me, I remember watching a documentary about the MAPS stuff, and I remember they're laying in bed with my wife and saying, looking at the two therapists, staring at this person in the bed with their clipboards, like, would you ever go on a trial like that? She's like, no, are you kidding? Like, look at the scenario. And it struck me, and it's the rhetoric struck me as unusual. I want to ask your opinion, because some people who are doing therapy with MDMA will argue that the MAPS trial is the therapy that they are the proponents of, and they want to sort of control this whole ship on the way along. My intuition is that psychedelics are powerful catalysts for one of many different, either pro-social or spiritual or ritual or tribal practices that will in many ways float all boats, except for maybe in psychology, like behaviorism or something like that, right? So I want to get your opinion of what you think about therapy versus quote unquote psychedelic therapy, and whether or not you are a proponent of there being a particular therapy for especially PTSD with MDMA and the sort of MAPS formula, because I agree with some of the sentiment that's been raised that veterans are the almost the definitive tribal people or tribal culture in Canada. You hang around with them, the way that they've come to heal themselves in these social circumstances, having their own little buildings inside of almost every little city and town where they hang out. Like, that's the way they do. And it seems the therapeutic aspect simply draws away from that. So just I'd love to hear your thoughts as someone who actually does the work.
That's super interesting. I'm not sure I'll be able to touch on everything you raised, but great question and comment. So thank you. For me, I've always seen like there's two distinct lineages, and one is, the kind of this psychotherapeutic psychiatric model, which really came out of, I would say it's a continuation of Leary and Alpert work from the early 1960s. It's the same model: peak psychedelic therapy, the PSI preparation, session integration. Our approach is still very similar. And if you remember, they wrote their book, The Psychedelic Experience, I think in 62, Erica, maybe, because they were trying to train a generation of therapists to use mushrooms therapeutically. So they wrote that book as a bit of a manual, and they based it on the Tibetan Book of the Dead. So that notion of the bardos and kind of crossing through, all that, getting too much into it. So that was the first, in terms of North American. I know there's more European psychoanalytic models that have been associated, but the dominant narrative is stuck, which is that you need this cathartic, relatively dramatic transformational experience. My research in psilocybin actually found that you can have more casual experiences that may not be as mystical, may not be as strong, but have a really strong after effect. The afterglow effect is really pronounced. And I've seen that with individuals who don't even have, they might have a muted psychedelic experience, but they have really profound alterations after, because we know there's associated changes in neuroplasticity. So as someone who does do the therapy, and as someone who's seen a lot of different therapies done over the years, I think the things for me that are quite interesting about psychedelics is if you're preparing people for psychedelics, you're preparing people to go into their unconscious, because the membrane is so much thinner under psychedelics. So you have to be aware of your issues. You have to work on therapeutic rapport and trust. You have to do parts work, and you have to do depth work. So you're doing all this stuff. You're talking about deep things that really, really matter. My experience in our trial, and I don't want to unblind our results or comment on it, but people do better immediately. They do better in part because it's really hard to get decent addiction care. You come into a tertiary care center, psychiatrists, all this beautiful setting. Of course, you're going to feel good and inspired. So people do better because they're part of, and they feel they're contributing to something, science, advancement. So they feel good. There's a motivation. They're making all the changes, improvements in their self-efficacy, but the relationship they have with me and the other therapists is profound, because I know what it's like to be in the psychedelic space. I've seen people lose their minds. I've seen them strip down to nothing. I've seen people panic. I've seen people find God. I've seen people revisit incredible things in their life, have the whole range of experience. And I always tell people, like, I've done so much drug-related work in the early days of needle exchange and harm reduction that nothing you ever do is ever going to shock or surprise me, ever. I've seen way, way more bizarre than you're ever going to do. But what you try to do is just give people an environment of safety and support and trustworthiness so they can unfold, where they can trust. There needs to be trust. So you talked about the two people with clipboards. It is awkward, but by the time they do that, I've known them for 10 weeks and we've done a lot of deep work together. And so then it's almost like an honor to be part of their journey. And really, you're just there kind of in case they need. Most people don't need a whole lot. I've seen people lay still for 8 hours and just have an inward journey, and we do the eye shades and the thing. There's a little bit of conversation, but I'm interested because I have two hats, because I've also done a lot of observational research in terms of ayahuasca ceremonies, traditional mushroom ceremonies, peyote ceremonies. And I love the power of ceremony, the power of song, the power of collective ritual. And so for me, that's the thing. Do we have to choose one or the other? Can we do some combination? But psychotherapists aren't shamans. Most of them can't sing or play music. So there's this whole thing. It's kind of in between worlds. It crosses worlds. So to me, if we're just going to do it, let's try to do it ethically. Let's be transparent about what we're doing. Let's have a clear idea what we're doing, be clear about our model and what we're expecting, not impose a lot on patients, but be really clear kind of what our model is. That really helps because people are going into the unknown. And just make sure we prioritize patient safety. I'm surprised, honestly, like Brendan, like the psilocybin in a psychiatric unit of a hospital is still psilocybin. It's still magic mushrooms. It's still, people have incredible experiences despite the fact they're right beside a locked wing with security. And it's in a hospital setting, because there's something with the power of that. As much as it's kind of dorky of two of us sitting there, the experience is still quite profound. So I don't know if that touches on everything. I'd love to hear more from you. I know we don't have a lot of time, but
no, totally. Thank you so much. I really appreciate your comments, and thank you, David.
Yeah.
So we don't have a lot of time, but maybe Gordon, you could ask your question as well.
Oh man. Okay, I'll try to do this fast. Thank you for having this, Ron. Yeah, 15-year Canadian Armed Forces veteran. I am taking over as head of engagement for Heroic Hearts Canada, deployed to Afghanistan, Iraq, Africa. Basically, your test baby of what a combat special forces veteran is gonna be. Lots of traumatic brain injury, blah, 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 blah. I did Ibogaine 5-MeO last January in Mexico. Psilocybin my whole life. That's beside the point. Other drugs, MDMA, in past periods of time, which have led me to believe like maybe has that helped me recover from PTSD more than my buddies have, blah, blah, blah. Okay. Still got my fingers deep within to the special forces within our within the Canadian military. Ketamine is happening. So it's already happening.
Yeah.
I've talked to some people who've done it almost 30 times now, and I'm like, dude, maybe that's not for you then. I don't know. But I have a buddy who is like basically intaking these guys and doing his own notes. He's sending them, and when they come back to him, serving, non-serving. Sorry if this freaks people out, but hey, we got to do this. Just like you said, if it's underground or not, that's what makes me most upset is that like, yeah, you're forcing this underground. So guys are killing themselves and it gets lost in the sauce. My question is, what type of research? Because I told them, yo, dude, you need to be like pairing this with like a university or someone because like this is critical information that should be given out. So I don't know, can you even use that kind of data, or does it have to be supervised by a university person? And I have a follow-up question, but I'll let you answer that one first. And if we don't have time, that's cool too.
I'm not sure I totally, what kind of data are you wondering could be included?
Can he give you guys or a researcher his notes? If he's taking like straight up good data downloaded, hey, how do you, before you go, these are your signs and symptoms, boom, boom. He's doing his own triage. Like, it's pretty amazing what he's doing. And
Interesting.
I was
Yeah,
like,
yeah, for
man,
sure.
you need to be talking to like one, like you or some of these people to get this
Yeah.
influence. Can that even be
for
used?
sure. Yeah, no, I'm a big believer in that kind of data is as important as in a randomized trial. Personal experience, that kind of experience people have had, particularly in groups that are marginalized, not well treated in healthcare, and have urgent needs. I think that kind of real world experience is super important. So I'd love to be in touch with any in that regard if that's what you're thinking.
Okay, cool.
And it's
And
nice to meet you.
good to meet you too.
Yeah,
I told
nice.
David, I was talking to him on our own messages. I'm like, I need to speak with this guy, please.
Yeah, for sure. For sure.
Can I ask one last question? It's very, it's
Yeah.
strange, but I brought it up to him today because he's concerned because the guys aren't getting, he doesn't think what they should from it with the initial dosing, because it's literal, like the classic psychedelic assisted therapy. Hey, we're gonna like dose you so that like you can talk through your stuff or go through your trip, whatever. When it comes to special forces, my own like, because he was telling me it's not working, and I told him, dude, that's why I began, and I know we're getting into like impartials here and there, but like the spirit of these guys and the control factor of like not being in control, and they don't understand that you need to submit to this stuff, and they don't understand that at all. So they're holding on so tight, but the ketamine, the dose that they're getting isn't strong enough to like break it. Whereas like I found that's why I like ibogaine, because like, dude, good luck, bro.
Yeah,
We'll
exactly.
see you on the other side. Is that like a thing?
Yeah. No, I totally hear you. I mean, my father, before he passed away, he was kind of funny because he said, Ron, I don't understand what you're doing, but I like what you're doing. And he was like, it was that point around surrender. Because I said, people kind of let go, Dad. You let go of, and my dad was very much someone who held it together just by his approach to mental health was intestinal fortitude, right? Just got it out, and he held it all together. And so the idea of surrendering was anathema to him, is foreign. And I think for a lot of soldiers, the notion and the wording of surrender is just, it goes against the grain of who they see their identity as. So I 100% agree. I think maybe we come up with different words of surrender. And I agree, ibogaine, there's no choice. You know what, I need to learn more about ketamine, really, to understand some of the risks going on now. I think part of what we need to do is we need to evaluate these ketamine clinics. We need to look at the patient outcomes. I don't think anyone's tracking them. There's a little bit. So just to understand more of the patient experience, where it's going. And I agree, there's a lot of veterans doing a lot of ketamine. So I would be a little, and that's why I'm surprised Veterans Affairs Canada is reluctant to kind of fund trials for veterans using other psychedelics, because so many of their veterans are getting ketamine, which is also not studied for what they're getting it for. And we know there's biological harm. So there's this funny thing, because it's off-label use and it's already approved, that it kind of anything goes. But trying to get something new, which is probably might even be safer biologically, has been harder. So yeah, let's stay in touch. I think those are great questions. It's a real pleasure to meet you tonight.
Yeah, you too. Thanks, Maps, for having hosting this.
Indeed, yes. Well done, Maps. Thank you.
Yeah, thank you, everyone. We're going to finish now with a talk, but thank you so much, Ron. It's been a pleasure having you. And this talk has been recorded, so it will be up on our YouTube channel soon. Just wanted to remind everyone quickly that MAPS Canada is entirely funded by public donations. So if anyone is able to donate, please consider doing so. There is a link in the chat. And thank you. Thank you everyone very much, and have a good evening.
Thank you, everybody. Take care.
Bye-bye.